In this video, we will discuss vasovagal reactions that can occur during percutaneous coronary interventions. We will discuss these reactions under following headings. We will first go through the incidence of these reactions, then we will see the definition, triggering factors, and high-risk patients associated with these reactions. Then we will go through the pathophysiology along with symptoms and signs, then differential diagnosis, finally prevention and treatment of these reactions and prognosis. The incidence of these vasovagal reactions varies between 3.4 to 13.9%. These reactions can be defined as a constellation of clinical symptoms and signs resulting from an inappropriate, usually self-limiting decrease in heart rate, blood pressure, or both, caused by neural reflex in response to a stressful trigger. Now let's go through the triggering factors that can provoke these reactions during percutaneous coronary interventions. Anxiety and extreme emotional stress, severe pain and discomfort associated with lidocaine needle insertion, arterial puncture and insertion of arterial sheath, removal of arterial sheath and the application of manual pressure can provoke these reactions during the interventions. The factors associated with the patient preparation like dehydration and prolonged starvation prior to the procedure, the antihypertensive medications like beta blockers, calcium channel blockers can provoke these reactions during procedure. And during procedure itself, the intracoronary injection of contrast agent can provoke these reactions. In past, use of ionic hyperosmolar contrast agent was associated with these reactions. However, nowadays, with the use of low osmolar non-ionic contrast agents, these reactions became significantly less common. Now let's go through the patients who are at the higher risk of developing these reactions during percutaneous coronary interventions. Young patients, especially females with short stature and low body weight, they are more likely to develop these reactions. Similarly, smokers, anxious patients with low pain threshold, they are at the higher risk of developing these reactions. Now let's go through the pathophysiology of these reactions. In response to triggering stimuli, either central pathway or reflex pathway gets activated. The central pathway is most common mechanism for vasovagal reactions, while reflex pathway, that is Bezold-Jerisch reflex, which is initiated by left ventricular barrow and mechanoreceptors, is most common mechanism in case of myocardial infarction, cardiac tamponade, and bleeding that can develop as a complication of these coronary interventions. Both these pathways results into enhanced vagal tone with simultaneous withdrawal of sympathetic stimulation that can result into either mixed response, cardioinhibitory response, or vasodepressor response. The mixed response is characterized by fall in both blood pressure and heart rate. The cardioinhibitory response is characterized by low heart rate with little or no change in blood pressure, while vasodepressor response is associated with fall in blood pressure with little or no change in heart rate. So the patient can present with transient cerebral dysfunction ranging from lightheadedness to a brief loss of consciousness, and this can be accompanied by nausea, vomiting, sweating, pallor, and hyperventilation. In patients with implanted permanent pacemakers, only fall in systemic blood pressure can be observed. Now let's go through the differential diagnosis of hemodynamic compromise that can occur during percutaneous coronary interventions. Before reaching to the diagnosis of vasovagal reaction, one first should exclude most important and most serious causes of hemodynamic compromise that can occur during percutaneous coronary interventions. So one should first exclude myocardial infarction, especially proximal RCA infarction, cardiac tamponade, and bleeding before reaching the diagnosis of vasovagal reaction. Now let's go through the various preventive measures that can be taken to minimize the risk of vasovagal reactions during these interventions. One should avoid prolonged starvation and dehydration prior to the procedure. If indicated, IV fluids before and after the procedure can be given. In case of patients who are at the higher risk of developing these reactions, beta blockers and calcium channel blockers can be omitted. In addition, adequate sedation and analgesia should be ensured. In case of femoral and radial approach, in addition to adequate local anesthesia and sedation, correct puncture technique should be used. In case of femoral approach, angiosyl closure device for the puncture site closure should be used, and if manual compression after sheath removal is being used, then additional sedation and analgesia should be used. In case of radial approach, hydrophilic coated sheaths and catheters along with intra-arterial vasodilators like verapamil and nitrate should be used. Now let's go through the treatment of these reactions. IV atropine along with simultaneous repeated bolus doses of IV saline or colloids is the first line of management. In the absence of peripheral IV access, intra-aortic atropine should be given, and if initial pharmacologic therapy fails, then inotropic support is indicated. In case of refractory bradycardia with hemodynamic compromise, temporary transvenous pacing should be used. Now moving to the prognosis of these reactions are usually benign. However, in case of patients with critical coronary artery disease with or without severe left ventricular outflow tract obstruction, these reactions can be serious and life-threatening. So these are the references you can go through for further details.